Just past the time, 2:30, so I think we should get ready to start. Can I ask everybody who's attending the session, please, to come and sit a bit towards the front? We have a big room. Will probably not be completely filled up, so it's nice to have people a bit closer by. For those who are not familiar with KIT premises, you are here at the Health Information Systems session. So if you're supposed to be in a different one, this is the one on Health Information Systems. Okay. I think we can start. So, good afternoon, everybody. Thank you for joining. This is the session about revitalizing and rebuilding a health information system in Gaza. My name is Ente Rood. I'm an epidemiologist working here at KIT, Royal Topical Institute in Amsterdam. And I'm going to be moderating together with my colleague, Nima Jagmai, who's sitting here in the front, this session today, this breakout today. And I just want to give you a bit of a background to why we're having this session here today. So as we've all seen and have heard already by the many speakers before me, the situation in Gaza is dire, it's rampant. We've seen the atrocities which have been happening, to the human lives lost, but at the same time, the complete collapse of infrastructure in and around Gaza. And I think it was mentioned this morning already that at the moment, only 16 out of 36 operational hospitals who used to be there are still functional. So the session today, of course, is about rebuilding a health information system in itself. And we've heard already remarks by other speakers this morning. People are not numbers, right? It's out there in the hallway as well. And I just want to echo that point. Because indeed, it's the stories about the people, right, which really matter here. There's behind every number, there is a person. But the whole issue and purpose of having a good health information system is that we want to show, and we have to show, that these are not isolated stories, right? We want to show that this is happening at scale. We want to show that the health needs are large and acute. So when we think about the establishment of a new health information system, it's to make sure that we have accurate data to inform our healthcare interventions, right? And it's not only about showing what's happening, it's also knowing about what's happening to these people. So it's not only talking about the surveillance, we're also talking here about basic medical infrastructure and medical records which need to be reinforced. So when planning this session and thinking about what we should focus on, we're very lucky to be able to talk to Dr. Yusuf Abou-Rish. He is the Vice Minister of Health, and spoke for half an hour with him about what he sees as the main needs. And he raised a few issues I would like to share here before we start. So the three themes he mentioned, actually four themes, which are really, really key at this moment, are knowledge about child health situation. And I think, the recent outbreak of polio, the vaccine-derived polio virus circulating at the moment, and the vaccination campaign resulting in response is a good example of that. We've also heard about the maternal health problems, right? The fact that the infrastructure is completely gone, and there's no knowledge about actually what the needs are, the most basic needs about public hygiene, for example. So he mentioned that as a key point. Of course, outbreak response. I mean, now we're dealing with a surge of diarrheal disease in the area. We've seen a large increase in cases. So that's also mentioned by the Vice Minister as one of the key needs. And finally, he stressed that we have to get a good view and good vision and know what the current infrastructure is, what are the medical commodities available, who are there to help, and where are resources needed once Gaza opens up. So these are the things, this is basically setting the stage, right? This is what was requested from us. Basically, the assignment we got here from the Vice Minister today to start thinking about, once Gaza opens up, what do we need to have in place? So designing this session, we came up with the following structure, and we want to take you along with that, and we really appreciate your inputs as well along the way. We'll start with a section where we have a few presentations. Some are videoed, some are live, but online still, to get a bit of grip of what the current situation is. What was the health information system looking like before the 7th of October, and what's there now? So that's just setting the stage. In the second part, we're going to invite some international experts online, but also in person here on stage, to share their experiences from other conflict-affected settings, areas in the world, where the healthcare system in general, or health information system, have been severely impacted, and what are the most immediate needs, what are the lessons learned, and what can we learn from that. So in the final part, we want to have a conversation about then what are the priorities, and that's also where we want to invite you to participate, about what are the needs for mostly, both with regard to resources, and when we talk about health information, we do not only mean, of course, servers and digital tools, right? We're talking about people, we're talking about procedures, we're talking about governance. It's very wide. So we want to talk about that, and then finally have a discussion about what is the best way, once Gaza opens up, to govern this, because we know there will be many actors who are ready to move in and provide help, and how can we coordinate this effort? I think this morning we already heard that we have to prevent duplication, we have to make sure that, that activities are aligned and that things are done in a sustainable fashion. So that's the final session will be about. So without further ado, I wanted to start immediately going into the first section to reflect on the status of the health information system. And thirdly, we have a recorded video by Dr. Zaher Wahidi. He's a director of the Palestinian Health Information Center, member of the Ministry of Health. He has a background in computer science, and as he's based in Khan Yunis in Gaza, he was not, of course, able to join us here today. And we're very thankful that he took the effort to record a video for us, which we will show here now. Please.
Thank you for giving me the opportunity to participate in this conference. Section 1. The status of health information systems before the war of extermination on Gaza. 1. An integrated information system covering all basic services, medical records, hospital system, primary care, health personnel, supply chains, financial system, maternal and child health, approximately 36 computerized systems in addition to 15 public service applications and 4 interactive mobile applications for services. 2. Monitoring systems for births, deaths, epidemics, and tumors, in addition to an observatory for health personnel in the health sector. 3. A health indicators system for more than 120 indicators in the field of morbidity and mortality, maternal and child health, hospital services, chronic diseases, tumors and infectious diseases. 4. GIS system for health services, identifies health centers and hospitals and the percentage of service coverage compared to the population, and excludes all private pharmacies in the sector, the spread of chronic diseases, and tumors. Section 2. Health Information System during war. 1. The health information system completely collapsed on November 10, 2023, after the Israeli occupation forces stormed the Al-Shifa medical complex and destroyed the main data center as well as the alternative data center at Al-Rantizi Hospital. 2. The successive outage of all hospitals in the north led to a lack of information related to the health status or even the ministry's ability to document the numbers of martyrs and wounded. 3. Hospitals operating in the south continue to operate on local systems not linked to the main data center and not linked to the population registry to verify the data of martyrs and wounded. Section 3. Efforts of the Ministry of Health to recover the health information system during the war. 1. Cloud servers were provided for the most important main systems. The Central Hospital System, Primary Care, Supply and Storage System, Births and Deaths, Medical Archives. Human Resources, Central Archives. 2. Building new systems that are in line with the current situation in the state of war, such as a martyrs data monitoring system, an epidemiological surveillance system, a system for medical transfers for treatment abroad, a health system for displaced employee services, a system for registering and evaluating amputations and spinal cord injuries, a system for managing field and private hospitals. 3. The ministry regained its ability to document data on martyrs and injuries in the war, verify the validity and accuracy of this data, and launched an electronic link to report martyrs and missing persons who did not reach hospitals. The necessary operational resources and infrastructure to restart the health information system. Emergency needs during the first phase. 1. The ministry restored 70% of the systems and returned to work in a limited manner due to the lack of operating needs of computers and network switches. 2. Providing computers, network infrastructure and backbone connectivity to operate basic services in hospitals and primary care centers. 3. Providing cloud servers for existing and new systems. 4. Rebuilding the main data center. 5. Support and development of software and information systems for a year. 6. Providing PACS system for main hospitals, Nasser Complex, European, Al-Aqsa. Second phase needs. Strategic needs to complete the operation of computerized systems to return to what they were before the war. 1. Hospitals and primary care needs of devices and equipment to complete the operation of systems effectively. 2. Developing the main data center and building a backup data center. 3. Providing PACS system for all hospitals and primary care centers that provide the service. 4. Support and development of software and information systems for a period of 2 years. Thank you for giving me the opportunity to participate in this conference.
Laisan, thank you very much. Zahari, of course, could not be here today, and I think it's clear from his computer background to use a computerized voice to make sure that the language barrier would not be an issue, and I hope you could see that. I think the big point, and also from what we've learned from the discussions with Dr. Aziz, is that there has been a full collapse of the hardware infrastructure in Gaza. I think it was reflected in his presentation. It must not have come out as strong as we've heard from others. So I think it's a point really to appreciate that the main infrastructure, including all the data servers, the hardware to operate, but also the people to operate these, are at the moment virtually absent, and we're relying on all the health clusters to collect most of their data at the moment and get the information which we currently are seeing on the screen and what people are referring to in their presentations. I would like to continue to straight away to our second presenter, was Ms. Wafa Zaidan, who is online. She's a health information systems officer at UNRWA, and she coordinates the digital impact technology and innovation department. She's been in the past leading the ICD-11 introduction into UNRWA, and she's been leading the methodology for health staffing and making sure that WHO standards are being adhered to. I think we can switch to an online presentation now. Wafa, can you hear us?
Yes, I hear you. I don't know if you display from your side my presentation, it will be good.
Yes, we can hear you very well. The floor is yours, thank you.
Thank you.
Wafa, go ahead.
Okay, but yes, thank you. I'm Wafa Zaidan, Health Information and System Officer in Headquarter Amman, UNRWA, and it is a good opportunity to participate in this conference. In this presentation, I will highlight the health information and the surveillance systems in UNRWA in general, and with specific focus in Gaza following the war in October 2023. The outline, I will go and give overview about the UNRWA health information system, key achievements, current health information system in Gaza, surveillance system, and challenges. Next, please. Yes. Now, e-health system in UNRWA introduced in 2009 within 139 out of 141 health centers are implementing e-health. The accessing to the central server, it is using different types of connectivity based on the infrastructure in each field. Of course, UNRWA provide primary health care and mainly maternal, child, NCD, general clinic, specialist, dental pharmacy, and lab, which is support the main program. And these services are fully integrated and functioning within the e-health system. The routine reports all routine reports now, it is generated from the eHealth. It means that's paperless. We developed the dashboards into Power BI to monitor and evaluate performance indicators, the KPI, for several indicators, and so we have several dashboards. Of course, the surveillance system, monitoring and reporting 19 diseases. Next, please. Now, we have several achievements, such as integration with refugees registration information system to provide us the basic or the personal information from relief department. Integration ICD-11, UNRWA was one of the earliest healthcare system globally to implement ICD-11, collaboration with WHO. We developed online training through UNRWA e-learning platform, developed mobile applications of MCH, NCD, and others. I will not go for each achievement, and now it is very clear about the icons. Next, please. Health information system in Gaza after 6 October. Of course, the health system has collapsed and the infrastructure. Disruption of electronic health system due to infrastructure damage, and this affected the entire health services provision. And health system or health information system is part from the health system, including surveillance. Healthcare provider record patients' data on hard copy and statistical table. Uploading to the SharePoint enable focal person to enter the data from multiple sites. Surveillance system to fit the context and focus on 10 plus diseases with pan-tipping potential based on the last discussion between WHO, Ministry of Health, and UNRWA. eWars now is running in 44 UNRWA sites, and it will be gradually to increase based on the resources availability. Across all the government or areas, including Mawasi, reporting on eWars platform. The data, it include water testing result, case investigation, nutrition, and cholera line list incorporate into eWars. Developed UNRWA Gaza crisis dashboard to measure the main indicators after the war. Next, please. Of course, we collect several indicators and data. We collect nutrition data for children from age 6 to below 5 years. Wash and to collect and to obtain some indicators, number of persons per toilet and shelter and showers. Collect diseases surveillance, and here it is very clear that the comparison between before the war and after the war, the increase. For blood diarrhea, 24 times increase, jaundice 388 times from October until August. Next, please. Of course, the accuracy of data, it is very important, and the quality. If we speak about the timing, measuring the delay between data collection and submission, this data, it is obtained from eWars, which is online. It is noticed that UNRWA reached 85% of the reports by day 4. And 85% represent the point where most data submission are expected to be completed. And when we speak about the completed, we speak about the first day or the second day of data reporting. indicating acceptable reporting performance. Next, please. Now we have several challenges. Instability of health information system, timely data collection and timely reporting, and manual record keeping affect accuracy course. Frequent population displacement complicated the accurate calculation and monitoring of health indicators due to the difficulty in determining the exact population size, and this it makes a problem to calculate some indicators. Overburden health workers, staff are focused on emergency care, which delay data entry and reporting process. Difficult to track the prevalence of common diseases due to disruption of health performance system, and difficult to monitor key health indicators such as maternal and child mortality, injuries treated, and vaccination coverage. We don't know the population, the exact number. Temporary funding can make also it hard for health information project to continue long term. Difficult health system don't work together, make data hard to share. Thank you. It is the last slide, and thank you for your attention.
Thank you very much, Wafa, for this presentation and providing that overview. And I think we can only, be proud and compliment with the fact that you've been managing to keep the system rolling as it currently stands. To end, we have a final short video presentation from Medical Action Palestine from Maram Al-Shufara. She's a health statistician working in the Gaza Strip at the moment, and she's been involved closely in the delivery of the polio vaccination campaign. Please.
Hello everyone, this is Mariam Shurafa from Medical Aid for Palestinian. I'm recording this video for the Health Information System session at the Gaza Health Initiative conference. I'm working as health statistician, being responsible for the follow-up of surveillance of infectious disease. About methodology, early warning alert response system, which developed by WHO and using to improve the disease outbreak detection in emergency situations. In consultation with WHO, MOH and partners, 15 locations were identified and approved to conduct surveillance of infectious disease among internally displaced people in shelters and camps. These locations include 9 in the middle area and 6 in Khan Younis. Surveillance was officially started by MAP team in April 2024 through 15 medical doctors at each location. In coordination with WHO and UNRWA, that surveillance team was trained over 2 days. The training refreshed their knowledge about surveillance principles and clinical case definitions according to 10+1 framework, and also provide guidance on the using of e-wards in a box application. Since then, the statistician has been submitting reports on the surveyed cases to the WHO team by weekly manner. Also, MAPKEEP coordinates with WHO to update these reports on the emergency medical team dashboard by weekly manner. Finally, MAP surveillance team faced some challenges, such as intensifying conflict and security risk. Also, multiple relocation and displacement of MAP staff and medical points. Electricity and power shortage, which exacerbate communication and internet barriers. From Gaza, thank you.
That was Madam Al-Shurafa from MAP. That was the final presentation we had in this first section, just to set the stage. And I hope you can only appreciate the fact that many of these people could not be here, but did go through the tremendous effort to record this and share this with us. So I just want to convey my thanks once again. I think that the main message here is that while there was a strong surveillance system before 7th of October, of course, with its limitations at time, at the moment they're just facing a huge difficulty in getting the information out, which leads us to this next section, which is on past learnings. So I would like to invite to the stage my colleague Nima Yakmai, Amrish Baju, and we have online Professor Paul Spiegel. And while you come up, I'll quickly introduce you. So Dr. Amrish Baju is an infectious disease epidemiologist and public health microbiologist and current director of Luxor, Operational Research and Epidemiology Support Unit for Medicine Sans Frontières, Operational Center in Brussels. He worked across a large set of humanitarian emergency and specialized in how medical data should be used. He's an honorary professor in the London School of Hygiene and Tropical Medicine, and he's worked in the past in the World Health Organization Health Emergencies Department. Online, I think we can hopefully have Paul on the screen, is Paul Spiegel. He's a physician and epidemiologist, director of the Johns Hopkins Center for Humanitarian Health. He's a distinguished professor in the practice in the Department of International Health at Johns Hopkins Bloomberg School of Public Health. And before that, he was a director of the Program Management and Support and chief of the Public Health at the United Nations, High Commissioner for Refugees. So these are our current panelists, and I want to hand over to my colleague Nima to lead the following discussion on past experiences. Thank you.
Okay. Thank you both, Amrish and Paul, for joining us today. So we've been presented with the challenges that currently exist with the health information system in Gaza. And challenges in health information systems in fragile and conflict-affected settings are not new. So I'm wondering, from the challenges presented today, Amrish, what experiences do you have on health information systems in acute responses? And from those experiences, how are they involved in becoming long-term strategies?
Can we have the microphone
You're
on?
here? Yeah, I think it's okay now.
Right.
So hello, everybody. Yeah, it's a big question to try to consolidate it. I think the first question is, what is the purpose of information in a different context? And I think before we go to what indicators we need to collect and what technologies do we need to use, it's really about the questions do we have. So it's about formulating the known unknowns. As an infectious disease epidemiologist trying to keep it close to infectious disease, it's really just generalizing it as an answer. What is the health status of the population? And what do we know about vaccine gaps? And I'm just going to name an example where I extensively worked in 2017 during the Rohingya refugee crisis. We knew that this was, for example, a population where vaccine coverage was incredibly low, and their origin in Myanmar, where they came from, that there was no access to healthcare. So that means, of course, like for the first time, it's about treating acute trauma and trying to document the data on acute trauma. And then secondarily, understanding what are the vaccine gaps and what diseases do we need to put under surveillance. And surveillance is not just hospitals or health facilities are kind of an endpoint, right? It's people come there when they're sick, when something is wrong, but you try also to look at what efforts you can do around, for example, community-based surveillance. For example, in the case of acute watery diarrhea or cholera, healthcare workers can detect these events quite early, and it means that you can have a response team kind of focusing on these type of areas. Similarly, at one point, if you then move from, and I'm just putting it in a very short text, if you go from an acute phase, which was 2017, and you move to what they officially call a protracted phase of an emergency, so the acute needs have not disappeared, but let's say the international funding and the international community is not having a spotlight on it anymore, and you go to this protracted area, it's also having this coordination with all the partners on okay, who is doing what, who is collecting what, how do we create the synergy in reporting? And I think for the acute phase in Cox's Bazar, it was just like it is in Gaza. There was a good example of the implementation of EWAR. You can't dictate what data partners collect and how they exactly do it, but you can agree on what the diseases under surveillance should be and what the events under surveillance should be, and therefore it can be weekly reported in an aggregated way, which means when you have one acute watery diarrhea case, that is important to know. If you have one measles case, that's important to know. If you have one polio case, it's important to know. But there are also diseases where you look at more long-term trends. You need a couple of cases. Acute jaundice syndrome is this kind of syndromic surveillance kind of event. Is also something you want to know, because it could be Hep C, it could be Hep E that is kind of developing in these areas. The other thing I wanted to add, just very briefly, when we speak about health data, and I've heard that fortunately mentioned also in this conference, it's the numbers and the stories behind the numbers. That means one of the things that we've been also looking at is how do you combine the data we collect from, let's say, the medical monitoring, the routine surveillance and monitoring, with data that primarily comes from our clinicians, so the statements, the witness that they see. So even as an epidemiologist, I'm not just sitting behind my computer and entering data together with my data encoders and analyzing it. You know, you need to be there. You need to speak with your staff. You need to speak with community leaders to understand what is happening before it reaches your systems. So all in all, it's tremendously complex, but there's also, unfortunately, I have to say, a wealth of experience across many organizations, and we do see that many of these emergencies tend to increase in trend. So I think as a health community, it's also the question of like, how do we utilize data better, not just for our operational decision making and our medical activities, but also for the advocacy. Because I think the medical statements are really powerful. We let our clinicians speak, we let our nurses speak, but then the body of evidence and how do we make this data speak, that's an important part. And I'm sure that Paul will elaborate much more on that in a bit.
Thank you so much. So, Dr. Paul, building on what Amrish discussed and the example he gave in Bangladesh, what are some lessons from other crises that could perhaps be applied to the situation in Gaza?
Thank you all. Can you hear me well?
Yes.
We can hear you.
Okay, great. Thank you, both Nima and Amrish. If I may, even just before that, I had the honor of, I was seconded to UNRWA in November and December, and I worked very closely with WAFA. And I wanted to put perhaps some context in terms of the system that existed pre-October 7 in Gaza and also in the West Bank compared to other emergencies. The system was one of the most robust systems I've ever encountered in an emergency, and in fact, it's better than many high-income countries. The system that existed, it was all electric. They had apps that would actually remind women for antenatal care. Much of what WAFA showed, and then, despite the destruction of the system, a lot of it was able to be put offline and used through computers. And so Gaza has been actually a data-rich environment compared to most other settings. And if we want to just do a comparison looking at what's happening in Gaza with data and what's happening in Sudan, it's night and day. And that's been incredibly important, particularly to what Amrish was saying in terms of trying to use the data, having the confidence in the data, then to be able to advocate widely. So if we want to look at the numbers of deaths that are being reported in Gaza, and try, even though some have criticized the quality of the data that is coming out in terms of death is much stronger than in Sudan right now. So that's number one, is I wanted to put that out there. Number two is that the biggest problem I would say across the board in many settings is that one is not able to do surveys in these situations. So it's very difficult to get population data. And the denominator, the number of people, is always difficult. And WAFA had mentioned this. That has made it difficult to look at rates and start comparing rates. So what often happens is we're using trends of gross numbers, how many people are able to get to a system. And so what we've seen here in, let's say in Gaza, looking at infectious diseases, it's very hard to get overall numbers of, let's say, for acute jaundice. We have the total number, but we don't have a very good idea of the numbers per population because of the incredible amount of constant displacement. And that's a problem that we always see across the board when you have a tremendous amount of displacement. Other than the easiest situation of a camp-like situation, but out of camps, we don't really know. It's very hard to get that denominator and then to compare rates. So WAFA had mentioned, for example, I think 24 times, I believe it was diarrheal disease. That's comparing the numbers before and after. But for example, the before October 7th, and I'll stop after this, UNRWA had data for all of their health centers. Primarily it was refugees, those who were registered with UNRWA. But when October 7th happened and afterwards, UNRWA opens it up to all registered and non-registered refugees. So the population, the denominator, actually it increases. And therefore, I think we have to be really careful of how we compare. And I think we also, in all situations, really need to try to look at the quality aspects, look at the biases, and then try to triangulate with various different sources in order to have an idea of what we can say and with the confidence with which we can say it. And I'll stop there for now.
Thank you so much. That was really insightful. Actually, you touched on something that was discussed before as well in another session, which is how Gaza perhaps differs from other fragile and conflict-affected settings like Sudan and Afghanistan, where they mentioned for the case with Afghanistan that Gaza has substantially higher levels of human resource capacity. And in this instance, you say compared to Sudan, Gaza's health information system prior to October 7th was quite significantly strong. For that denominator issue, are there lessons from other crises? I guess this question goes for both you and Amrish, where you were able to get those population surveys done in such a context, or did you have to wait for crises it to become a bit less of an acute crisis, let's say?
Well, yeah, denominators are our biggest issue indeed, always when it comes to measuring trends. And see if things are increasing or decreasing. And that's why, there's different ways to go about it. Like, there have been innovative methods, for example, in areas where you don't have an active war zone, where you can count households and make average census, or you look at the last census data from a country or from an area and try to extrapolate what it would be. But in a conflict zone, this is like all non-applicable, to say so. And I know that Paul has been doing a lot of work on these type of estimates together with some other researchers. So I'll let him do a bit of a deep dive into approaches in that.
Yeah, thank you. It is almost impossible to in this situation in Gaza and what's happening in Sudan right now, when you're having acute conflict and constant movement. UNRWA was doing an incredible job at the beginning of when people went into the shelters, and the shelters are primarily schools, the schools that are now acting as shelters. So they were able to document numbers of people, because Gaza is a different situation, and it's in some ways it's, quote, easier because it is a relatively small geographic area. You have UNRWA in particular for primary healthcare had huge, and still does, huge numbers of people that are very well trained. So it is a best case scenario in terms of data, despite how horrific. Obviously, I'm not trying to undermine what's happening there, but it was very useful. The problem was that it was very difficult to remove those people because of the constant movement. It was very hard when people were leaving those shelters, and or when the shelters became full and people are on the streets, to be able to address those denominators. What we also have done in the past, which is not perfect by any means, but we're desperate for data, so we will look at other sources of data. We'll look at, for example, food distributions and how many people are coming for food distributions as a proxy. Maybe we'll be able to look at if a vaccination campaign occurs, we can have an idea of how many children are vaccinated. Again, it's only those that have access. And then we can say, okay, if it's X amount under 5 years, and since we have good denominators and good demographic breakdowns pre-October 7th, we can then estimate a total population in a certain area. But it is really, really, really complex. On the other hand, we don't need perfection. And I think what Amrish was saying is one case of acute watery diarrhea or acute flaccid paralysis or a measles case, that's really key. And so we have some of these. It depends on the disease that we're looking at, and then the potential threshold for an epidemic. And then also there are other examples, and then I'll stop, in terms of, UNRWA had wonderful data in terms of how many people were receiving dialysis, for example. So we have an idea of how many people are on dialysis, how many people. We tried with WAFA when I was there, for example, to look at thinking about access to medications, and we knew how many people were on antidepressant medications. And so we were trying to look at, even though we didn't know the denominators, we looked at how many people were still receiving those medications. We had an idea, and then we tried to even look at that to know how many people were actually the continuation or the continuity of care, but all with a strong grain of salt.
Yeah.
Yeah, maybe just to add one thing, indeed, we speak about health information systems, and there's a few things that kind of go before that, right? It's, as we discussed, also the case definitions of certain diseases. We often see, like, when you put certain diseases under surveillance, which normally clinicians are also not used to seeing, but now because the situation changed and, let's say, the vulnerabilities and the risk change, it's important to train medical staff as well as in recognizing symptoms of certain diseases, especially in the absence of laboratory confirmation. And then also, like what I said, like before data enters a system, or let me say before a patient goes into the hospital, they're sick, which means that if you have one measles case that is detected on a hospital point and it goes to your health information system and alert is triggered, you can bet that there is a whole cluster of cases that is already developed. So there's two things to kind of circumvent the delays of health information systems. One is, and I keep on reiterating it because it's really important, have your ear close to your clinicians, because they will recognize things and they will tell you if there's something really out of this picture. And the second one is really, and it's difficult when you're in an active conflict zone, but for some diseases, having that community-based surveillance when the time is right to actually do it, because it's resource intensive, to have it displayed as well. And I would, let's say that the active conflict would stop today, and it's safer, then community-based surveillance is probably one of the first things you kind of need to go out into, detect things early and make sure that responses can be initiated there where the first cases rise. Because especially in areas where infrastructure has been so incredibly disturbed and diseases spread quickly. And that will be a key part of it in terms of also having these scenario plannings ready to do so and not just wait until the data has said something is there, because then it's escalated already.
Yeah.
Yes, Nima, if you allow me, just I have some comments about the population, and really it is one of our challenges. And maybe Dr. Paul was in UNRWA in December, and he know the system very well before the war and how we track the patients. And it gives us really clear information, and we can tracking these patients, and we can go exactly for our population. Of course, after the war, due to the displacement, the frequency of displacement, it became very complicated. And now if we say about, we have 1,000 acute jaundice, but this really out of from what? Of the population. Now, currently, we are working to calculate it based on approximately indicators that to attribute it for the medical consultation. If we say that, for example, we have XXX medical consultation, how of this consultation, for example, bloody diarrhea or any other diseases, that it is the only information now it is available. Thank you.
Great. Thank you for all your inputs from all three of you. I really do appreciate hearing about the creativity that is used in a health information system. Paul was mentioning different proxy indicators, and often when it comes to acute crisis, we give credit to surgeons and doctors and paramedics, etc., for becoming creative, and that also happens in the world of health information systems. It's great to hear. Last question for this section. From crises that outside of Gaza, is there a lesson learned to avoid going forward in Gaza? Paul or Amrish, go ahead.
That's a big question. Like, we always talk in humanitarian crises about lessons learned, and then we too often fail to apply the lessons we should learn simply because of the chaotic nature of what a humanitarian crisis is. I think, let me just put it in a more holistic way. Data is important to inform us on how to treat patients, how to treat victims, but too often we forget that especially medical data carries a neutrality of advocacy, which I honestly believe we don't harness sufficiently. Because it is true, as when it comes to what is most neutral of all, it should be healthcare. And especially like in different emergency, I've seen how important coordination is, especially on the aspect of data. And I'm happy to hear also from many of the speakers today that this is one of the things that we are learning, how to better coordinate, how to better pool data, how to better not just use data for the day-to-day informative, but also to advocate it. And the fact is that sometimes as an organization, you cannot use that data to advocacy because it has operational consequences, meaning that you're not allowed into an area anymore or your medical supplies get blocked. But there are ways we can be creative in sharing data with organizations that can, networks of journalists, academics that know how to echo our voices. And in this, I think, as a humanitarian community, of a community of health professionals, we should become stronger in that.
Right.
Oh, go ahead, Paul,
Yes,
if you
right,
had one.
please, Paul.
Or maybe just three points on that. I would say what UNRWA did, I think, also extraordinarily well very early on is, they had a very comprehensive system, and early on decided, okay, what is the minimum amount of data we need to collect to actually make decisions? And that was hugely important, because one of the mistakes that we always make, and particularly epidemiologists and others who love data so much, is, we probably collect too much data and don't use certain data. So one is that. But one of the challenges will be as this, when everything, when there's a ceasefire and there's a rebuilding, in stages, what is needed to be able to choose the data that are needed, because we can't go from A to Z. Obviously, it's going to take time. So that's number one. Number two is thinking about the data for advocacy and then neutrality. It's maybe my last point. This has been a challenge. So, for example, Amrish talked about, we also did projections, Hopkins and London School, to try to look for the future of what may be happening in the war as it continued on. And we've been trying throughout to use data to advocate, but we made a decision, which many people were not comfortable, that we stay neutral, is that the data are so clear of what is happening, I think, in Gaza. And as Hopkins and London School, we made the decision that we will present this data, we will remain neutral, and then others are able to interpret it and then show what is happening from who is being killed, the numbers, etc. And that can be controversial, because many people will say, now you have to use the data to then make various conclusions. But what we wanted to do was to use this data to try to, because it's so polarized, the situation and how the data and the quality of data, if we try to remain neutral and present the data, others can interpret it, and then we won't be seen automatically in this day and age of disinformation and populism of saying, well, they're on one side or another, and therefore their data and what they're presenting is so biased. And it's something to discuss perhaps in the future and as we move forward, because the data that will be collected in the future will not just be used for immediate decision making, but may be used in tribunals and other sort of, others as we move forward from criminal courts, etc.
Thank you. Over to Ente.
Right. Thanks, Paul. Thanks, Amrish. We'll continue the session with the same panelists, but I would like to invite yet another panelist to the stage. And I'm just going through my notes. Ms. Amal Arafif from UNRWA will also come to the stage. She's a health communication and community-based initiative officer at UNRWA. She has a background in inclusive education, and she's been working in Gaza for quite a few years. We will now continue the conversation. We've looked back now on what the situation is, what the learnings are from different settings. We spoke about creative ways of collecting information which otherwise would not be available. And the next part of the discussion, we'd like to focus on what are the priority areas going forward. I've started this session by saying, well, there is a clear request from the Vice Minister of Health to focus on certain health areas. We know that the infrastructure is down and low, while Gaza is still having actually quite robust surveillance still in place. But then the question before us is, once it opens up, what are the main priorities which we should focus on to rebuild and revitalize the system? So what's there, what we can still use, what will we need to add, what do we need to change? And I think straight away in line with that, and a very important question is, who's going to govern this? Who's going to be coordinating the efforts, and who's going to make sure that the information is collected, not duplicated, and shared to inform everybody on this. So these are the themes for the final part of the discussion. In this part, we would like to also hear some of the input from the audience. So if anybody wants to make a point, please raise your hand, and then we'll invite you to also to speak. But we'll start again with Nima, posing some questions to our panelists. Nima, to you.
Thank you. Yep, as Enta mentioned, feel free to jump in and provide your inputs. We're collecting all of the inputs that are going to be provided in this section of this session and taking it to the plenary afterwards. So everyone's inputs are welcome. I'm going to usually just frame a question towards the panelists, and then there can be some back and forths, yeah? So actually, I'm going to get to the second point first, because it was touched on already, which is what remains out of the health information system that existed prior to October 7th that can be used as a foundation. So multiple people have spoken on it, so it's clear to me that we're not starting from scratch. In fact, we have a very strong foundation and one that was really standing out. So from the panelists, I'm just wondering if is there a certain element of the foundation, element of what remains that can be really used as a foundation. And this element can be a physical thing, it can be an entity, whatever it may be. So, yeah, I guess first over to you, Amal. Do you have any inputs for that?
Thank you for having me for this opportunity. Actually, I'm not that expert in information system as the head of health communications, but I will, reply according to my experience during my work with UNRWA. Actually, as Dr. Paul said, and Wafa, we have a good structured electronic medical reporting, and the system is well structured in all our 5 fields of operation: Jordan, Lebanon, Syria, West Bank, and Gaza. So with the issue of electricity disruption, internet connectivity, this is the main issues that we face. All our health centers were well structured, had solar system, had internet connectivity. So we had all this data within our system. But with this current situation, wherever any of our health centers is damaged, no electricity, no internet connectivity, it's a challenge, actually. And with establishing of our medical points in the shelters and our new health centers in the open areas like Mawasi and other places in Khan Yunis, we try to have a emergency supporting system with laptops, with internet bundles to do our work and to continue uploading our data on our system. But the problem now is not only with Palestine refugees, because now we are expanding our services to the IDPs, who are already not part of our system. They are part of the MOH data system. So this here reveals the need for collaboration and coordination with MOH, with other UN agencies like UNICEF, UNFPA, and other agencies like even national and international NGOs. So we can collaboratively work and have really a good data collection and data system that we can build on later on. But for UNRWA, whenever the infrastructure is available, internet connectivity, we can restore our data, we can rebuild and restart again working on it. So it will be a challenge, but within the current circumstances in Gaza, with the frequent displacement of people, even with the staff not being even stable in one place or whatever, also it is a challenges, but even though we can manage whenever we have internet connectivity, electricity, and the idea of having the capacity of staff. They are overloaded. So the idea is the staff going to provide the service or do the data entry? Or are they going to really record the data or focus on the medical, service or whatever? So these are some of the challenges we had. But staff are there. We have trained staff, but we need to support them. We need to release them and give them the opportunity really to work in acceptable environment. Thank you.
Well, specifically, I can only speak from the perspective of the operations that MSF has in conjunction with the colleagues, of course. One of the things that we see when a situation changes is indeed you have to rethink what are the priorities from a very good functioning health system to making sure that you balance, like Paul also said, and you've mentioned, are sometimes data hungriness, because we want to know everything, to what are the essential things to know. And I think especially in such a situation, the emphasis at the beginning of any kind of conflict where you see a lot of trauma, so acute physical trauma, is indeed on that type of, type of injuries. How do we map them? How do we make sure that you link that to what you see in terms of what you can deliver? The second part is then, as something develops, you also know that there's more potential for infectious diseases to come into place. So you need to kind of agree, like, what diseases do you put under surveillance? And you have to be quite selective in that, because, as I mentioned, with quite some diseases, there's some overlap in case definitions, for example. And it means that you often don't have the laboratory capacity anymore to confirm if anything is real, and you kind of have to act on it. So, like, I think for me, those two are kind of like pivotal to the part. And I think what is really essential, and Paul mentioned and you mentioned as well, is that someone is going to have to collect the data, someone who's clinically certified on a case report form. Someone is going to have to enter that data. Someone is going to have to clean that data. And all these processes take time and energy. That's the simple reality if you want to have good data quality. That means it's better to have the most important things at first. And then maybe every 2-3 months, or as a situation develops, you kind of have to reconvene where you want to put the priority. And some of these things can be in continued priority, but it might also change over time. You will now have more cohorts of young children that have gaps in vaccination. So you need to put more of these diseases under surveillance. And then the question, of course, becomes, can we do anything about it? But indeed, when you see cases, this will be kind of the advocacy push that that the vaccination campaign can be engaged, and that's why it's important to collect that type of data.
Great, thanks. I'm getting an understanding that the foundation is there to start working, and the priorities that were mentioned by the Vice Minister, which were child indicators, maternal indicators, disease surveillance, and facility functioning, are good indicators to start, because they are the current priorities. Is there any additional priority that should be there? Maybe not indicators, but something else of focus? Anybody in the audience, or Paul, if you want to?
Mental health. Now it's very important to have some reporting for mental health well-being, and the percentages of people now, I guess, in Gaza having mental health issues is rising. So I guess we need even to have data on this.
That's a great point.
Sure. Number one is one of the first points I wanted to say was that we have to be very careful when Gaza will open up. One of the reasons we've had some success is that we haven't had 100 different NGOs and UN agencies being able to flood Gaza because they haven't been able to get in. And as we mentioned, UNRWA has, or Gaza in general, has very competent people. And so we need to be careful not to do what we often do, is once we can get in and agencies need to plant their flag, that we jump in. We need to actually make sure that we defer to those colleagues that are already there. And in that vein, actually, Nima, I don't know if Wapa is still around. I think that we should be asking her this question as well, because she is the person that actually has been responsible for this. So in that vein of not jumping in, I wonder if we can ask her what she thinks the needs are.
Yeah, sure. Waf, are you still there? Do you have any inputs on?
Yes, really, Actually, if we see now in the ground, we will see that there is multiple actors. They are working with UNRWA or in the ground to collect the data, and each of these actors have separate systems. My points here, in order to successful, and it should be this effort to collaborate with together in order to find some system and harmonize data collection and ensure system compatible will allow both organization and hospitals and agencies to manage patients' records and disease surveillance and reporting. Of course, to work separately or fragmented, each one to separate to another. I think this effort, it will be waste, and we will not reach for the good results and good health system.
Thank you so much. Actually, the section that we're supposed to discuss after, there's two main topics. The other one is about, working in partnerships and governance. So clearly we need to get to that. I just want to turn to the audience for a second to see if you have any inputs on strategizing and prioritizing. We've added mental health so far.
Hi, my name is Jennifer Davis. I work for a national NGO called Jazur for Health and Social Development, and I want to thank you all for this great session. First of all, I wanted to echo everything about talking about one system that everybody can report on, especially raising my voice to all international NGOs not to come in with their separate database that could fragment the health system again and the data that we're supposed to be getting. I want to prioritize more on nutrition as well as mental health and maternal health as well. And I wanted to say that there are a lot of efforts that are being implemented with gathering health data, and I think that we should prioritize accordingly, because if we see a trend of some kind of disease or disorder, we should work accordingly, because it's going to be too difficult to join in all data and efforts towards one subject at a time. And last but not least is that collective working is all that we need, and for international organizations not to come in with their separate data sheets. Thank you.
Great points, thank you. There was one more audience hand I saw. Yep.
Hi, I'm Sandra Rashid from ANERA. I want to thank Jenny, because actually this is one of the points that I wanted to make about the one system. We were working on a program pre-October 7th that looked at working with local organizations and health clinics to be able to have a complementary system that would be able to feed both into the UNRWA and the Ministry of Health system. But the idea now, we have a chance to create one system across the board that all could feed into and can be driven by the local people of Gaza in terms of what they need. So I just want to stress that and reemphasize the point that Jenny made about that. Thanks.
Thank you. Amrish?
Maybe first a short point on the one system. I think that is ultimately our dream anywhere. Even here in the Netherlands, we're dreaming about one system that all the hospitals are feeding into their data that we can collectively analyze. And even during the crisis I've seen here during COVID that we saw globally, it was almost impossible to do it. So the system is one thing, but one of the things that we should agree about is what indicators we are collecting and how we're coding them. Because the technology platforms are one thing, and I think that should be very much owned on a national level, but then organizations do have their internal reporting to do as well. I'm not saying this is good or bad, I'm leaving it in the middle. I'm just saying if we can agree about the data that we should be collecting and how we can collect it, you can at least collect it centrally in one system, independent of what organizations are using. Because we've worked, for example, I worked in Cox's Bazar in what we call the cluster coordination mechanism of WHO, and it was one of the purposes there where there was nothing at the moment to have EWAR, so that we could at least get aggregated data on diseases. So, we had a system that can actually trigger warnings for different type of things. I also believe very strongly it should be national owned, and it should be going through a cluster mechanism where you have agreements. But I don't feel at this stage we have to reach the advancement, and I'm skeptical if we will ever reach the point where we say, okay, this is a system we're going to use for all kinds of different reasons. The last point I wanted to mention, like on the priority. So we've been in the last years very vocal about elderly and humanitarian crisis, and I think it's the one group of people we often forget. And again, here I'm going to say, like, I can make a warm case, of course, why we're always focusing on children, but elderly have a very important role in our societies, especially when there is a collective trauma. They are memory in many ways when records have been washed away. They are the people that can have the convening power to bring us together. And often you see they're not caught in our age statistics. They're not caught very explicitly in our programming in humanitarian crises, and they play such a pivotal role in our societies of keeping them together. So I would like to make a warm plea to also enhance the lens in that. We did a bit in a scientific mode, a scientific scoping review to look at what organizations, both national as well as international, actually specifically look at elderly and humanitarian crises. And it was, I could count 5 organizations, maybe in the plethora of the thousands of organizations we have working in the humanitarian space. So that's the warm plea to focus more on that. And I think a lot of power of that is to be found on a national level as well.
Great, thanks. I see 2 hands up in the audience. I also see a tiny little yellow indicator, which I think is Paul's virtual hand stuck up there. So, Paul, go ahead.
Sure, thank you. Yeah, that is a tiny little virtual hand. There's one other area, and then I have a very strong plea. The other area that hasn't been discussed beyond mental health and nutrition is will be rehabilitation trauma. It's going to be massive, and so that needs to be discussed. And this isn't just going to be post-op, further operations in terms of people that have been wounded. It's going to be physiotherapy. So it's a whole other area that we need to look at. I think also, given what my colleagues have said and what I saw when I was there, is that the health workers in Gaza are so traumatized. They have not. It's not just that they've been working; they're like everyone else. They've been displaced multiple times. So there should be a very special program, I think, for them to be able to allow them to work. But that means they're going to need a lot of support, both physical support for goods, but also mental health. And then finally, and I don't think this will be controversial, but looking at what I saw in November, December, and then looking at all the other health systems that I've seen in humanitarian emergencies, there is a difference here. UNRWA deals with primary health care and with registered Palestinian refugees, and in Gaza they have an incredible system. And they cover 75% already of the people. And then those that are non-registered refugees, the Ministry of Health covers. So we already have a system that was functioning well. I would strongly suggest that everyone uses that existing system and not come in with their own systems. They have to report to donors, fine. But there is a system that exists for 75% of the population in Gaza already. So that is the system that I think people should be using. And then the other aspect where I think there's an opportunity is you then have another system from the Ministry of Health for those other 25% or non-registered refugees. But then there is an insufficient lack between primary health care and then secondary, or let's say the hospital system. But a system does exist in the hospitals. So there could be an opportunity in the future to link those two systems in such a way that you could have an integrated system. And in a massive, millions and millions of people, or hundreds of millions of people in some situations, in some countries, that isn't possible. But in a relatively small enclave in Gaza, that is possible. And we could develop a system there that is much stronger and integrated than we can in many other systems.
Thank you. Great points, Paul. I see 2 hands in the audience. I think it was over here and over there.
Hi, this is Rachel Mghani from Medical Aid for Palestinians. Well, I'd like to point that it's not only about deciding what are the priorities that we need to consider, it's also about addressing the main challenges that caused the destruction of the health information system. Speaking about the solar energy availability of electricity, the destruction of the infrastructure, infrastructures there in Gaza, those things that need to be addressed. Once those are addressed, we can rebuild the health information systems. I recall one of the examples, you saw my colleague Maram, who presented the presentation about the disease surveillance. In the same project, we also collect information on, we provide sexually reproductive health services. We are monitoring a set of indicators related to maternity care, like antenatal care, postnatal care, the number of visits, and etc. And by the time we started the project in the first 6 months, there was a lack of sharing of the information. There was a lack of reporting. The reason for that, when we asked the partners why they are not reporting on those indicators, the answer was that we don't have enough number of computers. So it's about, she mentioned, and Maram mentioned to me an example that two health staff are working on the same laptop. So at the same medical point, we have, for example, we have the pharmacist working and the GP doctor or the obstetrics doctor working there. So each of them want to enter the data. So which one of them, while they have only one computer in that, and sometimes they are working at a tent. So you can imagine the whole situation that they are working in. They're working in a tent. They have only one computer. They can barely charge their laptops or computers to work. So once we address the challenges, once we rebuild the infrastructure, we can think again about the priorities for collecting data. Reviewing all of the data that is being shared from Gaza, you can see massive information about all of the sectors, particularly about health, nutrition, mental health. There is a lot of information, a lot of indicators, but we need to know how to respond, more than how this data was collected, how it's going to be collected in the future, and how to address the needs that are highlighted through this data. More than, from my perspective, I think that thinking about rebuilding a health information system might be a later priority, let's say. There are other needs that need to be prioritized at the current stage. Thank you.
Thank you. The last question?
Yeah, maybe just a simple question. It's just because currently, obviously, there's no current sight at when the genocide will come to an end and when groups will be able to get in. But currently, there are efforts at building, obviously, field hospitals, such as what Auda is doing, and I think there was the Jordanian field hospital as well. Earlier, you said something that it's very difficult to gather, obviously, data from the population that is further removed from the UNRWA centers and hospitals. Do these field hospitals work together with UNRWA or with the other data collecting centers to properly process the data that comes out? And is there a effort in properly coordinating this effort to really get a full view on the indicators that we're looking at?
I don't know, does someone have an answer to that? I think getting field hospital data, the question was, is there an effort being put in to get field hospital data into UN UNRWA system, for example, to have it included?
Yeah. Let me just to clarify about, of course, UNRWA just provide the primary health care. So any case of need for hospitalization, we have a referral system for Ministry of Health or contracted with private hospitals. But here now the question that if we have our system that adapt or compatible with hospitals, other clinics, for example, UNRWA or a private hospital or private clinics, in order to enable easy change, analyze, and use coordinated public health efforts, and can be share this data and can be and the tracking about these patients. But in this way, again, I'm focused about the centralization system to be a centralization system that can be adapted on the ground of the situation. One thinks also to avoid relying, let me say, about or ensuring local health authorities and staff are empowered for sustainable and essential rebuilding system. If we speak about the one system, we need all the offers to work together and to benefit from the other, not in separate way. Thank you.
Thank you.
Mainly for primary healthcare services, to answer your question, the OCHA and the health cluster, there's a system where we have to all report on the 4 Ws weekly. And it includes basically all the information that the organizations are doing within the health. So each organization with their health records, they would upload what they have done during that week. And it's up to date weekly. And if you saw the presentation by Rick this morning, and all that information is usually taken from the 4 Ws.
Thank you. I think we have time for sound bites from our panelists. So we've spoken about the 4 priorities that were highlighted at the beginning. We'd added 2 clear ones, which is in relation to mental health and expansion into elderly care and physical trauma. And the discussion, of course, about, is the opportunity there for combining MOH and UN UNRWA's health information system and combining some of the primary healthcare information and tertiary and secondary. Sound bites, 10 seconds each of you if you can. What is the governance risk factor to make this possibility not work? Is there a risk? Is there an inherent risk that you see or challenge?
Yes, there's always a risk. Everything depends on how humble we as external organizations step into the arena of assistance. And at the same time saying, like, yes, what we need is strong coordination that should lie in the country. And we're there to support, which means, filling the gaps where they are. And I have heard it mentioned, international humanitarian organizations need to change their mindset on that front. Because in the end, there will be continuity and sustainability required, and that can only come from the country or region itself. And so we need to become a bit more humble in our role, I think, and needs to be less flag planting, which some organizations tend to struggle with at times.
Paul or Amal or Wafa, last one of you, and then I will pass it over to Enta.
I think Ministry of Health play a good role in this governance, and they should be coordinate and collaborate among various actors in order to centralize or decentralize the health information and the data, and to work together and how to share this data together. Of course, there is multiple actors, but those actors maybe again works in each of them in separate way in on their systems. We need to work or to harmonize data collection to be compatible, to be in one system. Thank you.
Great, thank you.
Maybe talking about some good practices that we have now on the ground is the specialized clusters. We have the healthy cluster, WASH cluster, nutrition cluster, health promotion cluster, where all stakeholders with MOH and WHO are working together. So I think this is one of the good practices that we should emphasize and go forward with it. Thank you.
Working together, thank you. Okay, over to you, Enta. Thank you to all the panelists.
Thank you very much, Nima. Thanks. And yes, we're over time, so I'm going to close this session. In summary, I think there was a lot of information shared here. I think the 1-2 messages which clearly came out to me is that whatever we want to emphasize on, it has to be under national ownership. It has to be coordinated. There's no parallel systems which will be useful here. And whether it's being an ICT solution, which probably is not even feasible, but at least having agreement about what we're collecting, what we're reporting is very, very important. I think it's also important to note that the thing we've learned and what we know about Gaza, there is a very strong workforce there. People are knowledgeable. They have been operating a very robust and effective surveillance system, and we need to build on that. So make sure that we don't ask too much, don't over ask, and ensure that we build from there. I'm not going to repeat all the good things which were mentioned here. I just want to thank the panelists, firstly, Amrish, Amal, Paul, Wafa, for your contributions. I want to thank the audience for being here, for your contributions. I have one general housekeeping remark. After this session ends, there's a prayer room available for those who want to make use of that, which is located left of the hallway at the end in the final room. And with that, I would like to close this session. Thank you very much for your attendance, and I hope you enjoy the rest of the conference. Thank you. 1 2 1 2.